Good afternoon, ladies and gentlemen. My name is Stephen Hermann, Student Physical Therapist Assistant, and this is my journal review for Primal Reflex Release Technique for treating plantar fasciitis. Plantar fasciitis is a common diagnosis found in the general patient population, and it causes roughly 1 million medical visits per year. The primary symptoms to be seen in plantar fasciitis is often described as a piercing or stabbing pain on the bottom of the foot, typically felt first thing in the morning or after a period of inactivity. In addition to the sharp pains, patients congruently can experience tenderness on the calcaneal tubercle, loss of range of motion of dorsiflexion, and an overall decreased strength of the foot and ankle complex. So what is a primal reflex release technique, or PRRT? It's quite an unorthodox method of downregulating an overstimulated nervous system in order to eliminate or reduce patterns of pain. This technique really focuses on addressing the neural system by taking hyperaroused primal reflexes and resetting them. This is done by providing 12 seconds of light but swift sensations in the form of repetitive deep tendon reflexes, or DTR, that either tap, rub, and stimulate the skin to inhibit painful areas which should cause an overstimulation to the autonomic nervous system and essentially tell the brain to shut down pain signals. Typically, plantar fasciitis is treated utilizing a 2 to 4 month stretching program or orthotics, and sometimes surgery in more severe cases. The PRR technique is thought to reduce pain and improve function in a much significantly shorter amount of time than traditional treatment methods. The purpose of this study is to observe the effects of the PRRT after one treatment on 7 Division I athletes, 5 of which had acute plantar fasciitis, 2 of which had chronic plantar fasciitis, meaning that the symptoms lasted longer than 10 months. Pain and functional limitations were the variables used in this study. 3 separate scales were given to the subjects before and after the treatment was administered. The first scale is the Numeric Pain Rating Scale, or NPRS. It's a scale to measure the patient's perceived pain from 0 to 10, 0 being no pain at all, and 10 being the worst pain possible. We students are very familiar with this scale because we have used it in nearly every single one of our comps thus far. The second scale is the Disablement in the Physically Active, or DPA. This includes questions relating to health-related quality of life, impairment, functional limitations, and disabilities, and it is scored from 0 to 64. The third scale is the Patient-Specific Functional Scale, or PSFS. Patients are asked to identify up to 5 difficult activities that are associated with their condition, and then rate the activities on a scale of 0 to 10, 0 being unable to perform the activity, and 10 being able to perform the activity at the same level as before the injury. The entire procedure of the treatment can be broken down into 5 steps. The first 4 steps involve the PRRT being applied to different areas of the subject's body while they maintain specific positions for each one. The 5th step requires the patient to grip 2 Q-tips with their toes while plantar flexing as much as they can. The total treatment time equates to only 5 minutes, about 1 minute or so for steps 1 through 4, and 2 to 4 minutes for step 5. In the first step, the patient assumes a supine position and the stimulation is applied just above and below the medial knee, and this is to reset the knee or SI joint. In the second step, the peroneal tendons are reset by applying the stimulation to them as the subject actively holds their foot in eversion. In step 3, the gastroc is released by simultaneously applying stimulation over the patellar tendon and anterior tibialis tendon, as you can see in the top picture. In step 4, the hamstring is released by simultaneously applying stimulation to patella tendon and hamstring muscle belly, as you can see in the bottom picture. In the 5th and final step of the procedure, as previously mentioned before, the subject holds 2 Q-tips in their toes by flexing them while simultaneously plantar flexing the ankle. If they started to cramp, then they would have to relax their foot until it went away, then resume the maneuver. If there's no cramping at all, they would continue the maneuver for 1 minute, rest, and perform it once more for a total of 2 minutes. Upon completion of the study, all 8 subjects were shown to have a significant reduction in pain and immediate improvement in overall function following a single treatment of PRRT. The PSFS and DPA scales from the initial eval to discharge had also shown a significant improvement in scores, as can be seen in the table below. 3 of the subjects continued to receive several more treatments of PRRT, which resulted in complete pain resolution. At the 2-week follow-up, 100% of the patients were symptom-free, and then at the 1 and 2 month follow-ups, 83% of the patients were symptom-free. So as you can see, the carryover of this treatment was pretty significant. I found several deficits in the strength of the research. The first being that the study discusses the effects of PRRT after 1 treatment. However, it doesn't really elaborate on the subjects who underwent several more treatments of it, i.e. the number of sessions and the frequency. The second thing was that the sample size and demographic for the study was limited to only 8 people, and they were all Division I athletes, so the study group was not very large or diverse. The third thing was that the tools used to measure pain and function were really limited to questionnaires and pain scales, as opposed to giving hard evidence of the use of MMT or GONI measurements to really quantify any sort of improvement that was made. There were a few things that I took away from this whole study. The first thing was that by thinking outside of the box and exploring non-traditional treatment methods, we can really give our patients efficient and high-quality care. The second thing is that the effects of the autonomic nervous system and how our patients really perceive their own pain is something that should be in the forefront of our minds and more carefully considered whenever we're providing treatment to them. And the last most important thing is the tools we utilize and the methods of approach we decide to take is really only limited by our own creativity. Thank you, and this concludes my presentation.